Thank you, Adam. As many of you know, nursing shortages, patient acuity increase, and uptick in behavioral health challenges have created this perfect storm in healthcare. Nurses are stretched way too thin, constantly asked to do more with less. This is causing 52% of nurses to consider leaving the bedside when shortages are already at an all-time high. This is causing leaders to think differently about how technology could help create a new model of care delivery. So, our next panel, virtual nursing. It's a thing, but where to get started. We'll share how to get the journey started in virtual nursing. I'd like to introduce our moderator, Lisbeth Votruba, Chief Clinical Officer for AvaSure.
Thanks, Dave. I'm really excited about this panel. Where to get started is a great title for this because virtual nursing is an emerging care model that we support, and specifically excited about having a conversation with two friends and colleagues and trailblazers in this. And both leaders are from organizations that have a very robust telesitter program already and are trailblazing in virtual nursing. So we have with us today Sarah Brown, who's the Vice President and Chief Nursing Officer at UnityPoint Waterloo Region, and Amy Hassel, Director of Patient Services for UC Health Virtual Care Center. At AvaSure, we conducted some market research earlier this year about virtual nursing, and we found 89% of the respondents, hospital leaders, nursing leaders, were moderately to extremely interested in virtual nursing, but most had not, none said they were fully implemented. Most were in some stage of planning, early implementation, or maybe one small pilot. Then last April, I attended a session at AONL on virtual nursing. They did an audience poll, and it validated the same outcomes that we found from our market research. And that poll was 80% were interested in virtual nursing, and only 2% had actually implemented it. So if you're on today and you're say, I know virtual nursing is a thing, I'm not sure where to start, you're definitely not alone. And Sarah and Amy are maybe a little bit out ahead of the curve, and I'm so excited to have this conversation. About a month ago, Sarah Brown and I spent 2 days in San Antonio, hosted by the Association of Medical Surgical Nurses. So Med-surg Nurse Certification Board is writing right now a certification for virtual nursing specifically focused on the med-surg space. And Sarah and I were asked to be subject matter experts there, along with nurse leaders from 7 other health systems that were in various stages of implementing virtual nursing in the med-surg area. And Sarah, you'll probably remember some of the conversations that we had, especially early on in the conversation, where I think we all kind of got goosebumps because we said, virtual nursing, we have to do this. We have to deliver care in a different way because of all the forces and the pressures on nursing right now. But this was a group of nursing leaders, by the way, facilitated, thank you, from Med-surg Nurse Association. But we wanted to take ownership, and we wanted to define it. And I think somebody even there said, we need to defend the scope of nursing practice. If we don't define what virtual nursing looks like, it will get defined for us, was something that we were talking about at that panel. And just so you know, that certification is slated to come out next summer. So nurses will be able to get a professional certification around this, and we're helping to shape that. So, hi Sarah, hi Amy, glad you could make it. And let's start with a kind of the beginning. What is the market problem that led you, or your problem in your setting that led you to decide to start virtual nursing? And then, just spoiler alert, a little later, we'll talk about your outcomes and see if the outcomes are helping to meet the problems. So with that, and Sarah, can you start from UnityPoint Waterloo? What led you initially to explore virtual nursing?
Thank you so much, Lizbeth, and thank you to AvaSure, an excellent partner for us here at UnityPoint Health. And so I really appreciate the opportunity to be here today. Want to talk a little bit about how we started virtual nurse. If you remember back to July of 2021 and where we were in healthcare, in the midst of the pandemic, it was a very challenging time, I think, for everyone in healthcare, for nurses specifically. We came together as a leadership team and said, you know what, this is happening, and we want to own our own destiny. We don't want to just allow this pandemic to happen to us. Like, we want to make some innovative changes. So we came up with this whole array of strategies and tactics that we were going to deploy that should somehow help us through this time. And virtual nurse in our med-surg areas is something that really grew legs, really was immediately helpful to our nurses at the bedside, and has grown astronomically quickly. So I would say the impetus for it was burnout of our nurses, not enough nurses. Some of the tasks and weren't getting done. Quality had taken a bit of a downturn, and we had to do something differently. And virtual nurse was one thing that helped us with that.
Thanks, Sarah. So Amy, at UC Health, you have been leading in virtual nursing way before the pandemic, but have ramped up even more so in the last couple of years. So do you want to, I mean, even thinking back to before the pandemic, and then also kind of problems that have led you to expand into different care models more recently?
Yeah, certainly. And thanks again for having me as well. And I just wanted to compliment AvaSure and Elizabeth as well. It's been great partners with Adam, Elizabeth, and the whole company. So I just really wanted to kind of give that shout out as well. So our journey has been started before the pandemic, and that's a little bit of the nature of how we're set up. So we have kind of a virtual clinical command center. One of the use cases that we had set up that we then grew during the pandemic and continue to grow is around some virtual nursing that we were doing with surveillance in our acute care and progressive care areas. And what we were doing is we have a virtual, like an EICU type workflow that probably many people are familiar with. But we're using that same resource. So an expert ICU nurse and providing surveillance and detection, initially aimed at mostly sepsis in our acute care and PCU areas, and really trying to help partner with bedside nurses who, even before the pandemic, are younger. It's often hard to find as experienced nurses. Turnover is, before the pandemic and now is very difficult to deal with, as we've all seen. And so really tried to establish kind of a high reliability process where we could mentor and extend sort of that ICU presence across our healthcare system. So we're 12 hospitals currently, and soon to expand. And so really the way that we're using the AvaSure platform is sort of our assessment when patients are meeting criteria for sepsis, and kind of, we're enacting a sepsis alert and supporting the bedside nurse with that ICU intervention arm. And then what we started to really expand that Elizabeth is referencing is now we're formally kind of pushing into initiating rapid responses as well from our virtual health centers. So we collaborate with some of our AI tools, and when we see signal, we're reaching out to that new, that bedsider, and who often is new, and really providing that mentorship and expertise. And the AvaSure platform is allowing us to join every sepsis or rapid response alert virtually and be a part of that care team, and really extend a small group of nurses. It's only 3 to 4 nurses typically that are in our virtual ICU that are surveilling up to about 1,800 patients in our healthcare system, and then being part of that team when that response is enacted. And so I know we're going to get to outcomes, but we've seen really powerful outcomes through trying to kind of change that healthcare delivery model.
Thank you, Amy. And thank you for allowing me to spend some time there recently, this fall, sitting with some of your expert virtual nurses, mentoring those newer nurses, and the emotional intelligence of those nurses that are working in the hub is so key. So I heard them overseeing sepsis response, for example, and they could overhear that actually the fluid that was ordered wasn't the right volume, but they waited for the right time to communicate that and communicated that back to the bedside nurse in an appropriate manner. So there's that mentoring piece is just such a high expert level of skills that they're doing at that level, and so that ratio is 1 to 600. So that's very interesting. So you're really aiming for high reliability, just looking at the most at-risk, clinically, physiologically at-risk patients, but at the same time mentoring those newer nurses. I also heard one of your nurses talking about during COVID, becoming the experts on COVID earlier, reading up on that, and then being a conduit for the bedside nurses and providing that support as well as an expert. Sarah, can you talk about your model's very different? Can you talk about your model of virtual nursing there at UnityPoint?
Yeah, it's quite different than what Amy is doing. And side note, Amy and I have some time to connect later so we can learn from each other on each other's programs. So ours is really integrated into the Med-surg care model. And so we have here in Waterloo, and we are now expanding this across the entire UnityPoint Health enterprise, but we have one virtual nurse essentially to roughly 100 Med-surg beds, give or take. And so the role that Med-surg nurse or the virtual nurse plays, she will do all of the admission questions. So everything outside of the physical assessment, she will do. Currently, we are using some carts. The wheel the cart in, have the discussion. She will document everything. Some of our Med-surg nurses at the bedside will actually have then the virtual nurse scribe their physical assessment. So the nurse at the bedside would verbalize, as they do the heart and lung assessment, and then and all the other assessment pieces physically, and then the virtual nurse would document that for her. So that's been well received as well. They work on care plans. She works on virtual patient education. She checks core measures. So if someone is newly diagnosed for certain diagnoses, there's certain things that we need to make sure are completed in the hospital or follow up. She'll help make follow-up appointments. And the thing that has been best received is the discharge process. And so she actually, as soon as there's any indication that a patient will be discharging, she's actually compiling all of that discharge information, putting together the discharge packet, ensuring that they have follow-up appointments made, ensuring that their medication reconciliation has been done appropriately. And through that process is where we have seen just leaps and bounds in quality and some great catches. A couple that I would really like to mention, I think, and I had it written down, I think we've had about 107 things that I would say could have had significant patient harm had they actually happened and the virtual nurse caught them. And I think, we could say the nurse at the bedside probably will catch them as well. I think the difference is that virtual nurse has the opportunity to be so focused on that work without all of the distractions that our nurses at the bedside have. So a couple that I would mention are, we had a patient that was about to go home. She realized that they were on 2 different blood thinners that we needed to get corrected very quickly. We had a new diabetic that had not had insulin, that was going home on insulin, that had not had any insulin education. Obviously, that's a huge deal. A new CHF patient that was not going home on the appropriate medications that we as nurses know, that is a must-have when they go home. And so I think it's shown its worth in a lot of different ways, but I think most meaningful to me, and I know to our clinical teams, are those clinical catches that we've got these eyes in the sky that are going to make sure that our patient goes home with what they need.
Sarah, those examples that you gave are huge readmission risks. So the impact on the individual patient is really immeasurable on their quality of life. But is there also an impact on the health system for a diabetic patient a patient on blood thinners, a CHF patient going home and coming back to the hospital for another admission a few days later if this was missed.
Yeah. We are just, I'm almost afraid to say it, but I will. We are just now seeing indications and trends that discharges completed by the virtual nurse and that patient going home, they have an actual lower rate of readmission. So if that correlation continues and is a true correlation, that will just be a huge deal for us. And I think across healthcare, right? If we can get this specific piece done really, really well by a focused individual, and it leads to a decrease in readmissions for that patient, that could be huge.
A huge impact financial and quality wise for the hospital. Amy, what about some of your outcomes for the rapid response, the sepsis patients? What are you measuring? And I always love to hear patients' stories as well as data to make it real.
Yeah, absolutely. I think that's where we're all here. It really matters. And so, Sarah, it was really exciting to hear about your work. That sounds very powerful. So thank you for sharing that. I think in the sepsis bucket, we've been in this journey a little bit longer with sepsis, as I sort of spoke about, and the trends that we saw sort of pre or post out of the gate was a pretty significant reduction in non-present on admission sepsis mortality. So that was what we really, were looking for. And then we've just seen our compliance go up, and I'll share patient stories here in just a moment. Regarding deterioration, though, this is an interesting one where it's a little bit harder. Sepsis is obviously a little bit more pointed and maybe but not always obvious, but potentially, there's more of a checklist and a bundle to follow. How do you sort of set up a high reliability process around rapid responses, meaning that we're finding deterioration sooner, recognizing that, moving the patient through a rapid response. And then where we've seen real value is monitoring the patient post-rapid response with the AvaSure platform and sort of letting our VICU, our virtual nurses, stay in place with that patient when the rapid response physical member nurse has to leave to go see other patients. And we help to continue to monitor that patient. So what we've seen is an increase in the amount of rapid responses we're calling across our healthcare system, both with what we're doing in our virtual center and also with it's a partnership with the local nurses for sure. And what we've seen is a code blue reduction rate in our acute care areas. And so it varies by, which hospital, what region. We're up and down the Colorado Front Range, but we've seen anywhere from a 25% reduction to, in some of our facilities, a 70% reduction in code blues, which is really unprecedented. And a lot of that has been impacted by the work that we've done training. It's not just this, but it's in partnership with deterioration education and things like that. But it's been pretty significant. And I think we're a patient story and kind of a win to share was when we're in that post. If the patient stays on the floor, we monitor that patient with the AvaSure camera for 6 hours post rapid response to see which way they're going to trend and see if they're going to continue to deteriorate. And one of our virtual nurses happened to notice that a patient, was post-seizure, recovering, newer nurse who was a little unfamiliar. So she kind of provided some guidance and noticed that the patient was probably going to throw up. And so she just walked the nurse through, you want to make sure you have suction, turn them on to their side, do these following actions. And they were able to get the doctor back to the bedside, assess that patient and save the patient. I mean, it's hard to prove a negative, but I think save that patient from aspirating. The bedside nurse was super appreciative of that guidance, that mentorship. It was a kind of a panic moment of like, I've never seen this. I don't know what to do. And at that point, the rapid response nurse in the physical building had left to go to another call. And so again, I think we're able to kind of scale that expertise that is so hard to find these days, in an ICU kind of critical care setting. And we've just seen resounding support in our patient outcomes. But I think also in this day and age, we've seen our bedside nurses feel so supported through this model and having this access that they've been very appreciative and feel like it's a give back to them as far as maybe their charge nurse isn't, they have a patient load and can't always support them, or the rapid response is stretched more thin, those kinds of ideas. So we've seen some good wins that way.
Wow, there's so much to talk about in that answer, but I'm going to start with I've just got zoomed back to nursing school, studying the Benner model of novice to expert. So we have novice nurses at the bedside, and then we have this expert nurse that they can call upon virtually. An expert nurse is someone who everything congeals together almost subconsciously, and that expert nurse needs a video for this, but that patient's going to throw up in 5 to 10 minutes. And that comes from years of experience, and it becomes almost an intuition. And knowing also if that patient does throw up, they might aspirate. Aspiration pneumonia has this % mortality, and this is and that is a med-surg setting. It doesn't have, they don't have suction easily available. I've got to tell the new nurse to go get suction ready, all before the patient throws up. I just love that. So that, and I want to maybe take a little time talking about that expert level, and that practicing nursing at an expert level virtually. But I cannot move on without just stopping for a minute, and just your outcomes are incredible, Amy. And I actually didn't know this ahead of time. So
They're hot off the
increase.
press, so it's fair. It's fair. It's early data, and I should stress it's early data as far as this piece. I mean, we're 3 to 6 months in,
Yes.
but I do think with the pieces we put in place and changing culture along with this support, I think we're hopeful that trend will continue. So.
And just for people who are listening, and I actually implemented rapid response team back in 2007 at Mercy Health St. Mary's, and that was a positive KPI for us. More rapid response calls. So you started with, we've increased in rapid response calls. I just want to make sure everybody knows that's a good thing. More rapid response calls does lead to less code blues, and I'm just thinking of people in the room from AvaSure who might be engineers or working in other areas. The code blue means cardiac arrest, and cardiac arrest in the hospital, we do resuscitation, but if you get that far, the outcomes are not good. The percentage of survival is not good, and people who do survive a code blue or cardiac arrest often have brain damage and don't go back to the same quality of life. So I just want to pause for a moment and say, wow, we're decreasing code blues. The impact on just a few individual lives is incredible, and it gives me chills. So thank you for sharing that. Now let's get back to the nurse. That is doing the virtual monitoring. And I think this is one of the benefits that we've probably all heard about, and reasons to explore virtual nursing, is this is a way to retain or extend the career of a nurse who may not, who may love nursing, love this high level of expert nursing, anticipating, using their skill set and experience. Mentoring new nurses is a very fulfilling thing to do as a nurse, as well as patient education. That's very fulfilling too, just to kind of help someone not be afraid to take on managing their diabetes themselves. So I've sometimes heard, oh, virtual nursing, they take the tasks that nobody wants to do, or they document, or they are practicing nursing at a very high level. And Sarah, I want to give you a compliment too. I was able to sit with your virtual nurse, and she talked about how fulfilled she was the day before. She had done some service recovery before discharge with a patient, and she was able to take, she said, I needed to take more time with that patient and their family, and I took more time than the bedside nurse could possibly have taken. So tell me a little bit maybe about your patient experience, if you're seeing an impact on that, as well as how do you hire and train these special nurses?
Yeah, I'm glad you talked about the experience, because that experience piece is so important. If you think about the role of the virtual nurse, they are able to kind of pull back out a little further than the nurse at the bedside can do, and really get a good picture of what is happening with that patient. And so I think they're able to catch more things because of that. That experience piece, we've looked for people with a few years at least of med-surg nursing. We've been fortunate that we've had virtual nurses with much more than a few years, but they bring a different level of critical thinking and just, I think, wisdom from that experience. And so they catch things more easily. From a overall quality perspective, we've had some pretty significant increases with the great catches with the discharges specifically. I would say from a patient experience perspective is where we've really shown some great data. And so I actually have this written down, so I'm going to cheat off my piece of paper here so I didn't have to try to remember it. And these were pretty recent. So for patient experience, after the virtual nurse discharge implementation, there was a 7.64% increase in patient understanding of the purpose of taking their medications. And I think it was a lot because they were so focused on that person on the screen. Whereas when we're going in and out of a patient room, sometimes it can be hard to have that same level of focus. And then a 2.04% increase in discharge information top box scores. And so we saw those dramatic increases with the virtual nurse implementation. I would also say there were some other soft things that we noticed. So two that I would talk about are the virtual nurse didn't have a mask on. The whole rest of the hospital had a mask on. And the patients really talked about their appreciation for talking to somebody that could actually smile at them and actually have some, emotional receipts when they were talking. So they really appreciated that. We actually had a couple of patients that were hearing impaired, and they were able to communicate more readily with the virtual nurse because they could read lips easier. We also can connect the virtual nurse with interpreter services quickly. And so that has been a huge win as well. I think when the bedside nurse has the virtual nurse scribe, the bedside nurse then is narrating. So they are saying, I'm hearing diminished bases in the lungs, and it creates this really awesome conversation. The family will say, well, what does that mean, diminished bases? And so then they're having a different kind of a conversation, which has been great. I think the other thing I would mention is the experience of our bedside nurses. So it has saved 12 minutes per admission and 15 to 29 minutes per discharge. That's real time that we're taking off the plates of the nurses at the bedside. So a lot of wins.
Whoa. Okay. I'm going to start with what you ended with. Taking documentation time away from bedside nurses, allowing them to spend more time with other things that must be done in person. So both on admission and discharge, taking a chunk of time off the plate of the frontline nurses. And that is just extremely important right now when sometimes ratios are getting stretched or there's higher acuity and maybe isolation rooms causes a lot of donning and, so many things that take up the time. And I read a study, and I'll have to find the reference for this, where nurses, and this is kind of an old study, I think it was 2015, spend 25% of their time documenting. And so just a call out to anybody in the chat, if you have a good reference for how much time nurses spend documenting, I'm looking for that, because I think that's really important to set the stage of what the problems are. And documenting is nursing practice. So I don't want to diminish the importance or the critical thinking necessary on documentation, but just those chunks of time that you took on and as a gift back to the bedside caregivers is incredible. And then I also want to reflect a little bit on your patient experience, measurable HCAHPS, patient experience scores. And I think that the patients are saying they're more ready to understand why they're taking their new medications. Again, that I can connect dots from that and the discharge process over to preventing readmissions as well. So I know you said that was early decrease in readmission rates, and because that takes a time to measure, but I think all indicators are that that trend will continue. How about on your side, Amy? What do you look for in having virtual nurses for years now? What characteristics do you look for when you're hiring a virtual nurse?
Sorry, I muted myself. I think you hit a lot on the emotional intelligence piece. I think you want an expert nurse, but just because you're an expert doesn't necessarily mean you have that right skill set for this type of work. It does have to be somebody who really is very collaborative, loves to mentor, loves to teach, that kind of precepting, nurse who loves to just kind of empower others and really share that expertise and has that emotional intelligence, because it might, I think to folks who aren't as familiar with it, it might seem easy, but you're right. There's an art to when you're interacting, and you want to make sure that we're always very cognizant and wanting to stress that we're a collaborative partner to the bedside nurse, and that they're first and foremost with the patient. We're playing a very instrumental role, but we're a partnership, we're a team, and really looking for that person that has not only the expertise, of course, and that clinical skill set, but really that desire and heart to teach and teach collaboratively together.
And Amy, are you seeing any impact on patient experience? I know you're across how many? Tell me, it's a lot of hospitals.
Currently 12, soon to be 13.
13 hospitals. So maybe it's a little harder to measure direct impact on patient experience. But are you getting anecdotal feedback on that and/or on bedside staff satisfaction with the program?
Yeah, I mean, to be honest, it's hard to make it a direct equation, I think, in this particular work stream with patient satisfaction. But again, early days, we've done this for the deterioration part, not so much sepsis has been a little more hardwired now for a couple of years. But we've really seen, and particularly in one of our regions where we saw the 70% code reduction, just kind of an outpouring of, we have a platform where nurses can recognize one another, like, thanks for being a great teammate, like you really helped save the day, that kind of workflow. And we get just oodles, our nurses get oodles of these since we started this program, and back and forth. And I encourage them to send those as well. Like, hey, you did a great job in that rapid response, and really kind of supporting psychological safety for those nurses, because sometimes that can be, it can be a scary event for a new nurse to call rapid response and feel empowered to do that. So I think that's where we've just seen an explosion of positive energy, which is, really needed with morale and just with how, flexed up people are right now post-pandemic, or, post the surge of the pandemic. And so we've seen really big wins, and we haven't been live long enough to really equate that directly to staff retention. But I've heard from our CNO leaders across the system how thankful, where we've launched this program, how impactful it's already been to really support their staff. And so I think that's been really powerful and neat to see.
And I will say that one of your nurses, staff nurse from Medical Center of the Rockies, stopped by our booth at AONL, and she was like, "Oh, we love this. We use this for a rapid response." So that did my heart well.
Well, that's good to know. Good to know.
Yes, yeah. And I had fun shadowing there at Medical Center of the Rockies too. What a fantastic facility and great view.
Yeah.
So I'll stick with you, Amy, for a minute. We have hundreds of customers, and those who aren't customers are thinking about implementing AvaSure. And as you heard from the stats from the market research, there aren't very many hospitals that have implemented something like this, but many are thinking about it. There are a lot of chief nurses that have been, this is one of your strategic tasks, or strategic goals for this year is to implement virtual nursing. What can you share with them that was a lesson learned, and maybe help them even making maybe a mistake that you made, or just lessons learned, I think would be really helpful for those who are listening.
Yeah, I can speak to that first. I think I think it's kind of what I hit on, at least from my perspective. I think that whatever process you're designing, it really has to make sense and kind of solve a need at the bedside. Like, I mean, this seems intuitively obvious, but I think a rookie mistake, or at least, something that I learned as I went through this process is that you can have all these technologies and whistles and bells, but it's got to make sense for the person at the end, the end user. It can't be harder. It has to be easier for them.
Mhm.
It has to make sense for a problem you're solving, and it has to be integrated in a way that makes sense that you're building a team effort. And I think really making sure that when you're rolling out programs or new initiatives related to kind of virtual nursing in different avenues, because we've done a couple different focuses, I think making sure people understand what it's meant to be and what it's not meant to be is really clear. And you really need both that kind of senior, CNO leadership support or executive support, but you also need buy-in from your managers and your frontline nurses, out of the gate. And so I think really sitting and spending time with them of what are the issues you're having? Like, where are your pain points that you think this can help you? Versus, hey, I have a solution that's sort of looking for a problem, I think is always going to go over better. And it's also not that hard. I think a lot of times it does seem intimidating to people, but it really, once you kind of have those conversations and understand where you're wanting to kind of go after and help solve and integrate with, it becomes a pretty amazing partnership, I think, to see happen.
So not implementing not implementing a solution without knowing what the problem is.
Yeah,
You
I
said
think
it better.
having end users tell you what the problem is always helpful. Versus,
Yes.
hey, I have this idea for you, and they're like, I don't need that.
That happens more often than you would think.
It happens a lot in virtual work.
A lot in
There's
virtual-
a lot of people with ideas. Yeah.
Yeah. And then it's not as hard as you think. And there was one more big one that you just said. I'm just trying to.
I think just having the buy-in again of both local leader, like you want senior leadership support, but you also really want the buy-in of your frontline leaders and your frontline nurses. If you don't have that, you're going to lose them in this process. I feel from the work that we've done to date.
Excellent. Oh, and then you said, and when you're implementing, make sure that it's understood what it is and what it isn't. I think that's key too. Yeah.
I think we've seen things, everybody contends with this, like with Big Brother, these kinds of things, what it is and what it isn't. Like, we're not, kind of really shaping the partnership and that culture, I think is really key. And it sounds silly, but I think really calling out what you're meant to do and what this isn't meant to do. These types of programs, like, we're not here to audit or, do these X, Y, and Z. We're intended to support you and scale expertise and kind of solve some of these pain points that you have identified yourselves that say, this would be helpful.
Excellent. How about you, Sarah? What have been some important lessons that you've learned?
Well, Amy said that really beautifully. I'll just add a couple things. I would say be willing to adapt as people give you feedback. So, we thought that we wanted this to be a virtual admission nurse. So initially this was called VAN, and we had a little emblem created. This was virtual admission nurse. Within about 30 days, we had clear information from our bedside nurses that they really liked it a whole lot more for discharges. And so we adapted and, we surveyed the nurses. We did a whole bunch of rounding, spent a lot of time with them, and we made a lot of changes based on their feedback. So I think early on, assumptions that we had made weren't exactly right. And I would say just be willing to adapt as you get the feedback. The other thing I would say is just have courage to try something. We MacGyvered our first, sets of technology, and we picked a unit where the leader and the nurses are super adaptable and flexible, and we just tried it. Grabbed our CEO and we went upstairs. We pretended to be patients. I mean, we just try something, create some buzz around it. And I think there's a lot of work in this, but it's good work. And so I would really recommend for people to give it a shot.
That's really two good things I took from that. One, on the admission versus discharge help. And it feels like the patient starts with an admission and ends with a discharge. So we should start with admission and end with discharge. But if you are really looking at patient flow problems and bottlenecks, you have to start with the discharge in order to make space for the admissions to come in. And if there's some organizations have a little bit of challenge with bottleneck in holding in the ED, and you really have to start with discharges in order to make room for those. So that's great that that's what the nurses also wanted help with. And then the second thing was you chose a unit that was really adaptable and kind of maybe had that culture. So what I'm hearing is maybe you chose based on culture even more than the unit that had the most need? Or did it happen to be kind of the both?
Well, I don't know about everyone else, but all of our units have a great need.
Okay.
So it wasn't as much about need. It really was kind of about the, the change management readiness, I think, of that particular department.
That makes a lot of sense. I'll stick with you for a minute, Sarah. So what's next? Where do you see this going in the short term and in the medium term? What are you excited about?
I definitely want to learn from Amy, so I'll put that on my list. So currently we're using, carts, and they're not all matching. And across our enterprise, we have a lot of different things that we're using. We had this thought that we were going to do what we could with what we had, and so that was our approach, and we ran with it. I think now we're really looking for a standardized, sustainable structure across our enterprise for technology. For all of the things that we're going to need, job descriptions and all of the things that come with the operational logistical aspect of virtual nurse. We do want to standardize that. We're hoping for some sort of centralized leadership structure so that we have some consistency there too. So we have a lot of work to do in that space. From what the virtual nurse does, we do want to go down the path of, can they do things like check blood with our bedside nurse, verify high-risk meds, jump in on a rapid response, maybe document for the nurse on a code. And then that mentor coach piece, which is near and dear to my heart and has been from the beginning. To me, that's when we get this thing matured enough that a nurse on night shift that's never put an NG in before, nasogastric tube for those non-clinical people, they can just dial somebody up and they can walk them through that. The beauty and power in that's where I'd really like to see us get to.
Yeah, and I think that in Dave mentioned that the intent to leave or considering leaving the profession is creeping up, and especially among novice and new nurses, as it was before the pandemic. And now if they feel isolated, if they feel like they don't have resources, that makes that worse. So this is a great tool for retention and having that helping hand and security of knowing that you can call on someone for chest tube or something like that. And then on Amy, what are you looking to for the future?
Yeah, so we've rolled out recently some virtual wound care and virtual respiratory therapy programs that we're continuing to scale and kind of hardwire further. Wound care is one that we've seen a pain point as far as how do you scale wound care expertise as well across the system and, in healthcare. And wound care nurses are even more of a unicorn, I think, than, some of the other types of nurses. And so we're really trying to scale those resources. And we're also looking at a similar workflow that Sarah just spoke of, where we might look at, more of that kind of virtual nurse in the acute care setting. So we're in active conversations with our acute care leadership folks and asking the same questions I think that Sarah brought up. Is it admissions? Is it discharges? Where are your pain points? And I think your point was well taken about iterating, because that's key to this work as far as hearing what they want and what their needs are and how to make that better. So that's some areas that we're starting to push among a few.
Excellent. We have some time for Q&A, and a lot of questions have been coming in. One of them I'm going to throw at Sarah first is just kind of about how do you triage which patients are most appropriate for a virtual nurse to do the admission or discharge, because I heard you say one virtual nurse to 100 patients, so that virtual nurse isn't doing them all. how do you decide which ones the virtual nurse should help with?
I think our virtual nurse currently is doing around 55 to 60% of our admissions. So just to kind of, level set on the data piece. Within those, the work queue that the virtual nurse gets, she is triaging which ones she should do first. So she has that within her work. I think the nurses at the bedside also have some critical thinking around, should I send this one off to the virtual nurse or should I keep this one myself? And so I think they would base that on, complexity. Maybe it's somebody that they see having a high deterioration index, or somebody that we think might not do well. Maybe they were admitted and we're thinking maybe they need to be at a higher level of care. They're definitely going to do those admissions themselves, probably on the floor. But I think one of the key pieces, and I wanted to make sure I mentioned this, was the communication between virtual nurse and nurse at the bedside happening all day long. I think that's just a really key piece in all of this working.
Great. Do either of you see any impact at all on the nurse to patient ratio, or how do you answer questions about that? Does this impact your bedside nurse to patient ratio? Amy?
For virtual deterioration work right now, it's not necessarily changing the ratio at the bedside. I think, one could argue that maybe we would have added more rapid response nurses brick and mortar. But we haven't really seen that in this workflow. I think, that's something that we're more just scaling resources at this point, and we're doing it in a pretty efficient way as far as, it's only 3 to 4 nurses that are then serving almost, 2,000 beds and things like that.
Have you got any questions about that, Sarah?
Yes. So we haven't yet. We use hours per patient day generally in nursing, and we haven't included the virtual nurse yet. I would say intention is over time as we actually include it in the care model even deeper, and maybe we decrease the scale of how many patients that virtual nurse is covering, and the work that they're doing. I definitely do see that we would have it included in those hours in some way.
Okay, that makes a lot of sense. And I think there are some questions that have been written in, but I've asked the two that I can see, so I'm just trying to see if I could get a scroll of some other questions that have been written in. Okay, I think I remember one of them was kind of about the form factor of devices, and I know, Amy, you kind of have a mix there. So can you talk about what kind of devices you have in patient rooms, and does that vary depending on the care model?
It does, and so we actually have the AvaSure platform deployed in both mobile means in our they're not really older, but older facilities. But Colorado has the strange problem of just like we're actually still building hospitals. Colorado's growth the population is growing, it's exploding. And so we've actually built 3 new community hospitals in the last several years, and actually are still expanding in almost all of our healthcare system. So our footprint moving forward is we actually are installing a camera in every room. So we have ceiling cameras in our newer facilities. And as we go forward, that is our standard. In our existing facilities, it's very difficult, obviously, to get into every single room and try to get that wired and get that installed, infection prevention and those kinds of things. And so we have the mobile camera, and I think the ceiling camera obviously reduces the burden for the nursing staff to have to find it, that kind of thing. So that's been a win for us, but we're also able to make the mobile camera workflow successful as well.
And then, Amy, also the form factor or kind of the equipment set up for the virtual nurse, what kind of applications does the virtual nurse have in front of him or her?
Yeah, for the way that we're set up, and again, this, is probably, depending on what use case, you don't necessarily need such a as much as we have, I guess. But in the sense of how we're set up for what we're doing, we have kind of a 6-screen configuration, and we're an Epic shop. We use Epic, and then we use a tool called Epic Monitor, which some people are familiar with, a lot of people aren't. It sits on top of Hyperspace, and we have tools and kind of workflows, and then we have AI tools and some scoring tools that we've set up to kind of scan in the background and look for deterioration and or signs of sepsis, and again sort of serve that up to our virtual nursing team so they can review that patient and take a look. So they typically will have a headset, their tools in front of them. We have different phone systems. We're not unified in our healthcare system. And so we use Vocera, we use Cisco, we use Ascom, we use whatever you have. And so we use secure chat. And I think, Sarah made a good point. Communication is key, and, really making sure that you're in constant communication, however you're doing that. So that's typically what our kind of cockpit station looks like, in the way we're interfacing with the data and making notifications.
Thank you. Well, we're running out of time, but thank you both. This has been enlightening, and kind of a theme that I heard is, I guess the Nike theme, just do it, is one. And another is that this nurse is at the top of the game, and an expert nurse, and I would love to see a virtual nurse be something that somebody might even strive to. And so there are different career paths in nursing. I mean, I had a real strange career path, but you could be a bedside nurse. You don't have to just become a nurse manager, a nurse director, through the administrative path, but you could become a rapid response nurse, or, when I get more experienced nurse, I want to be a virtual nurse, because it's a very fulfilling position and has a huge impact directly on patients and on nurse colleagues. So thank you both so much for sharing with us today, and trailblazing and helping to define a new way to deliver care that is so needed right now.
Thank you.
Thank you.